Hey guys, and welcome to the cardiac lecture for paramedic refresher. The objectives for this one is to have a better understanding of the basic cardiac physiology with some electrophysiology, and then um, better understanding of assessment and management of the cardiac patient. And I totally understand that most guys and girls taking this class are experienced providers, and so hopefully this will be just a good brush up on some physiology along with the videos that are in this class, and um, and so here we go. So the cardiovascular system anatomy, right? The anatomy of the heart. So it's the size of approximately the patient's closed fist. It's located in the mediastinum, right? So between the lungs, in that space, and it's anterior to the spine and posterior to the spine, which is, extremely convenient for performing CPR. 2/3 of the heart's mass is to the left of the midline, so it's no big surprise to anybody that the big meat of the muscle is in that left side or in that left ventricular portion. Just a couple of anatomical orientation type things is that the apex is at the bottom of the heart, located just above the diaphragm, and that the base is at the top of the heart at about the level of the second rib. So you've got your three tissues of tissue layers of the heart, right? You have that endocardium that lines the heart's chambers. If you were to dissect the heart, or for those of you that have done either human cadaver or pigs, that porcine model, that it's very slick on the inside, right, to decrease that frictional rub. The myocardium's that thick middle layer of the heart, and it looks like skeletal muscle but behaves just like smooth muscle. And it contains those special structures called intercalated discs. And they speed the conduction of those electrical impulses, right, from one muscle to another. And it's the death of that myocardium that causes the results of any sort of myocardial infarction, hence myocardial infarction. And then the pericardium, is that it has the visceral pericardium, the parietal pericardium, and then that pericardial fluid, right? And so that fluid kind of helps to decrease the rub, and then those two linings help as well. Well, keep the fluid in and decrease that friction. So here's just a picture of the heart, or a diagram, a pictogram of the heart. Right, you've got the left and right sides. It's the superior and inferior. So you've got on the superior aspects, both left and right, you've got the atria. That's where the blood comes from. That's where incoming blood comes from, and the atria is going to be separated by that the interatrial septum. And you've got the ventricles, both left and right, and they're in the inferior portion of the heart, towards the apex. They pump blood out of the heart, and they're going to be separated by that interventricular septum. So some more anatomy of the heart, right? And we're talking about the valves. So you got that AV valve, or that atrioventricular valve, and that's going to be blood. It's going to control that blood between the atria and the ventricles. So there's two of them, right? So you got that tricuspid, which is the three-leafed, hence the tri, and that's the right atrioventricular. And then you got that mitral, or the bicuspid valve, which is going to be that left valve, right? And those are going to separate between the atria and the ventricles, and then both halves of those, both of those valves are connected to the papillary muscles in the ventricles, and the chordae tendineae, what connect the valves leaflets to the papillary muscles, and this is what helps prevent kind of that backflow of blood back into the atria. Some more anatomy of the heart, right? You get the semilunar valves. You've got the right semilunar valve. You've got the left semilunar valve. So that right one is also called the pulmonic valve, or the pulmonary semilunar valve, and the left one which is going to be between the right ventricle and the pulmonary artery, is between the left ventricle and the aorta is going to be that left semilunar valve or the aortic valve, right? It's going to be easier to remember as the aortic valve, right? The one that separates the left ventricle from the aorta. And then here's just that blood flow through the heart, and then as you saw in the Armand Hazuda video, or you should see, he does a really good job of tracing all the blood flow through the heart, and he does it in about 5 minutes in a pretty entertaining way. So be sure you hit that portion of this class. It's located in the same section as you found this lecture. And so back to blood flow. Again, I'm just going to refer you to the pictogram, or to that video of the drawings. And so in that anatomy of the peripheral circulation, so once the blood has left the heart, right, that's where we're going to pick up now. So, in this pictogram, or this picture, or this drawing, you've got on the left side the vein, on the right side the artery, and then that kind of blood vessel piece, or that center piece that shows kind of the heart pumping to the systemic circulation on the right, and then returning on the left, right? And so, for a lot of new sort of folks, that, people may even think that blood kind of goes out on the left side and comes back on the right side of the body, but we know that that's not necessarily true, right? That's just where it re-enters the heart, or on the right side, and leaves on the patient's left side. Okay. So when we talk about the collateral or peripheral circulation, the layers of peripheral blood vessels, right? As you look at the picture, we have, right, this nice little. We have blood flowing down the vessel, right, and then hydrostatic pressure, or blood pressure, forces blood or fluid out of that capillary, and then osmotic pressure, or those big proteins, right, also called oncotic pressure, kind of pulls that fluid back into the vessel so that it can return on to the venules, and then from the venules it goes to the veins, right, and then from the veins it goes back to the heart. Okay, so it's super important, or where we're looking for, and you may remember that term net filtration. That net filtration, right, is basically that the force is favoring versus filtration versus the forces opposing filtration should equal about 0, and that way we have no stagnation of fluid in that interstitial space. And we commonly call that interstitial space edema, right? That's where fluid starts to build up, and so that's why one of the reasons that you have that the ascites in the patient with a very cirrhotic liver, or that peripheral edema. One, it can be just a circulatory issue, right? The vessels, or we're not pumping out, we don't have the ability to really pull fluid back in. But a lot of times it's going to be that there's that liver disease, decreases protein production, and that protein pulls that fluid back out of that interstitial space and back to go into the systemic circulation. So just a real quick picture of the arteries and veins. Just remember that there's those 3 layers, right? There's the tunica intimata, the media, and the adventitia, right, which is the outermost. You'll just notice that on the artery, everything is more robust and muscular, versus that the venous system, which primarily, remember, relies on the movement of the body and the closing of valves to help get fluid going back to the heart. Okay, so the anatomy of that peripheral circulation, you're all well versed in the reality that in the arterial system pushes blood away from the heart, and it functions under higher pressure, and in that venous system it carries blood back to the heart, and it's under that lower pressure. And so that's one of the reasons that a vein or a neck injury that has the potential for venous injury, we have to be very careful of and have an occlusive dressing on, because the pressure inside that vein is so much less than in the atmosphere that is potential for an air embolus to get into the vein and make its way to the heart. And there's just a little picture of a dissected human heart. So in the cardiac cycle, right, you've got the diastole and the systole, and that first phase of the cardiac cycle is going to be the diastole. It's a relaxation phase. It's the lower number. That's when ventricular filling begins, and the pulmonic and aortic valves are closed. And then in systole, that squeeze, right? It's that contraction. It's the second phase of the cardiac cycle, and the tricuspid and mitral valves close, and the pulmonic and aortic valves open, right? So it allows the ventricles to push out the stuff, right? So either that newly oxygenated blood to the the left aorta, or allows blood to go from the left ventricle to the systemic circulation. Okay, so the ejection fraction is important because that's the percentage of blood ejected from the ventricle basically in one squeeze, right? And it needs to be about 60 to 70%, or about 70. So about 70%. So the stroke volume is going to be the actual amount in milliliters ejected by the heart during one contraction, okay, or during systole, and that's going to be about 70 milliliters. So remember, volume has to do with the amount of stuff, and the ejection fraction has to do with the percentage of the amount of stuff. So some factors that are going to affect that stroke volume, and remember, in the average individual, it's going to be about 70 milliliters, 60 to 70 milliliters. It's also called the end diastolic volume, and it's going to be the amount of blood in the ventricles after they have been filled during diastole. And then that cardiac contractile force is going to be the strength of contraction, right? So a weak contractile force or a weak cardiac contractile force doesn't allow for much blood to be pushed out of the heart. And over the course of several beats, especially in the early onset, we start having stagnation or backing up of fluid, right? And that leads to a whole litany of potential problems, from pulmonary edema, i.e. From congestive heart failure, or peripheral edema, just to name two. And then remember Starling's law of the heart. Remember you can only stretch so much, and it contracts very hard. So the afterloads, that resistance that must be overcome during the systole or during the contraction, and in order to get that blood out. And it's determined by that amount of peripheral vascular resistance. So it must overcome any sort of resistance outside the pump itself. And so when we talk about managing, or some things that are important to know, it's maybe not as important to know it's good to know, but it's not exactly like, it's not like you can't function as you're well versed in the sympathetic nervous system, or knowing kind of where all these innervations occur. But it is important to know that depending on the condition you may find your patient in, like particularly like a head injury or a spinal injury, that has significant overtones to what may occur inside the heart, right? So in the sympathetic nervous system control, it's going to innervate through the cardiac plexus, and that sympathetic nervous system control, or that innervation, is in both the atria and the ventricles, right? So while it's tied in, it's also important to know that from an electrical impulse standpoint, that, remember, the heart is the only muscle in the body that produces its own electrical impulses, right? It's got the ability, or that ability is called automaticity, right? And that's one of the things that really comes into play as we start to defibrillate or cardiovert, and think about trying to kind of reset that heart's ability to beat at that, hopefully, SA node. So the sympathetic and parasympathetic are kind of the yin and yang, right? They're in constant kind of battle or balancing with each other, right? Trying to find that stasis. And that in that parasympathetic nervous control with the heart, right, that occurs through that vagus nerve, right? And I think most of us are very familiar with, the call to the bathroom where that patient has had that vagolytic response, or to a place where somebody's been sitting for a long time and they stand up too quickly and they get that response, that vagolytic response, and the next thing you know, they're doing a header into the floor. So the parasympathetic nervous system primarily innervates the atria. Okay, so there's a picture of the electrophys of the heart, right? So the SA node, right, that pacemaker node, starts kind of high in the high arch of the ventricle, of the right atrium. And then as we innervate down through the septum and then move out kind of at that apex, and then innervates back through the left and right ventricles. Okay, so those intercalated discs, they're special. Between cardiac muscles, they kind of increase, or they do increase the rate of electrical conduction from one cell to another, right? And like, it's so important to have that continuity from that SA node all the way through the atrial and ventricular septum, or septae, and then in through the apex, and then the outer portion of the myocardium for both ventricles. So the synctium, or the group of cardiac muscles that function together as one unit. You got the atrial, goes from superior to inferior, and in the ventricular, they go from the inferior to the superior, and that's what helps to force blood from the ventricles up into the aorta and the pulmonary artery. So you get that classic picture of the cardiac depolarization. So in that P wave, you got that atrial excitation. In that, right, just at that kind of Q wave, you get that atrial systole, and in that QRS, we lose a lot of stuff because it gets overshadowed by that ventricle, right? The more powerful, or the more it has more voltage, or it has more amplitude. And then, as we move across, you've got your S, right? You got your J point, and then you got that T wave, right? And that T wave is going to be that ventricular repolarization. And then the U wave, depending on the patient, right, or what the device that you're using, you may or may not see that U wave. So real quick, a real quick review of cardiac depolarization. So remember, the sodium potassium pump is super important. That and this comes into play particularly on patients that are dehydrated or potentially even overhydrated, right? As an example, some people on medications that are having difficulty managing the potassium or sodium levels. So the inside of the resting cell in that myocardia, or that myocardial cell, is negative in relation to the outside. So there's more sodium ions, or positive ions outside, than potassium ions on the inside. And so that's the resting potential, right? So you see the kind of number one, you've got the ATP that's going to be necessary to get some stuff moving. Okay, so then when the cell depolarizes, it suddenly becomes positively charged on the inside in relation to the outside. So then there's more sodium ions on the inside of the cell than there are on the outside. And so that's going to be called your action potential, right? And then the contraction of the cardiac muscle occurs when those cells depolarize. So that electrical stem occurs, the cell membranes to become permeable to sodium ions, and so they rush into the cell. This causes the cell to depolarize, and then the heart contracts very quickly, and then from that, very quickly, the membrane again becomes permeable to sodium, and it traps the sodium ions inside the cell. Okay, so then the membrane becomes permeable to potassium ions, and they diffuse out of the cell. So the cell becomes negative in relation to the outside, and then that's repolarization. So that sodium-potassium pump is just constantly and actively transporting sodium ions out of the cell and potassium ions back into the cell to completely restore those resting conditions. Okay, and then in that conduction system, you got specialized conductive fibers that transmit that electrical stimulus, right? And for depolarization, that goes rapidly through the heart so that the heart can depolarize in the right direction, which we can all agree, I think, is very important. There's your conduction system, right? You got your SA node, posterior wall, the right atrium. It's the pacemaker, and it beats at 60 to 100. Those internodal pathways, they conduct that depolarization impulse to the atrial muscle and then to that AV junction. And that AV junction, right, slows the impulse just for fractions of a second. And then that AV node, which of course is located in the floor of the right atrium, if it were to fail, like the SA node were to fail, the AV node, right? So we just kind of work from superior to inferior in terms of pacemaker sites. So it's that constant backup. So if you have that breakdown at the SA node, or the SA node impulse cannot transmit from the base to the apex for whatever reason, or even to the AV node will take over and it will function as the pacemaker site and will set it about 40 to 60 beats per minute. Okay. So at that AV node, right, then we've got the bundle of His, or the AV bundle, and they start in that AV node and then they go into that ventricular septum, right, that thick, meaty separation between the two ventricles. And then those bundle branches form when the bundle of His divides. Okay. And so you can see on the picture where that AV node is and then where the bundle branches begin. They carry the impulses to the apex of the left and right ventricles. And you got your Purkinje fibers, right, and they transmit that impulse from the myocardium of the ventricles, starting at the apex, so that they travel up through the ventricles, right? So we squeeze from bottom to top, or superior to inferior. And if for whatever reason the SA node's not working and the AV node's not working, well then that or they're not receiving those impulses, then it'll set its own pacemaking rate, and that'll be 20 to 40 beats per minute. And then at that point, usually the patient, if they weren't previous, is extremely symptomatic. So, speaking of symptomatic, we'll kind of move into that assessment of the cardiovascular patient. Okay, so like this is not new medicine for you guys, right? You're going to do that scene size up in an initial exam, or if you've come out of paramedic school in the last 3 years, you'll see it called the primary assessment, and then the focused history, or the secondary history. So you got that chest pain or discomfort. Never forget to use that OPQRST. That's the common mnemonic that's used right throughout our profession. They may have dyspnea. They may have a cough. It may even be a productive cough, right? Because it's not like they have their cardiac issue in a vacuum. They may have some other stuff going on as well. Some other related signs and symptoms, right? Diaphoresis, restlessness and anxiety, and that feeling of impending doom, along with nausea and vomiting. And those, right, those things, this one and this one and even this one, right, that's going to be that sympathetic nervous system. And that sympathetic nervous system is going to be pretty difficult for somebody to fake, right? So when you see that diaphoresis, that restlessness and anxiety, that feeling of impending doom, that nausea, vomiting, right? That's a real good indicator that something's going on, that body's going like, hey, I don't really care for what's going on. And again, that's not life in a vacuum. They may have something else. Maybe they're out running or whatever, and they're diaphoretic because they're not really diaphoretic. Or they're diaphoretic, but they're just sweating because it's hot outside and they've been exercising, right? Fatigue, palpitations, edema, right? headache, syncope, and maybe trauma associated with that syncope. Okay, and that anguished facial expression, that it hurts. But I think for those who have experienced it, when that patient says, "I think I'm gonna die," and they're not like joking around or like being fatalistic, they're just for real deal saying, "I'm gonna die." Usually, that's a good indication that something you're getting ready to do a lot of work, because that's usually a telltale. So continuing on, right? You get your focused history. You want to check the allergies. Are they allergic to anything? Medications, including erectile dysfunction medications, right? Male and female. Past medical history. One of the great indicators, or one of the great things that kind of leads you to they're really having a heart attack is, yes, I've had a heart attack. Okay, does this feel like that last heart attack? Yes, absolutely. Well, winner, they probably have a heart attack going on, right? Last oral intake, and then the events preceding the incident. So what were you doing before this started happening? So while we're getting those good signs, or we're getting those good symptoms from that patient, let's also do a real good job of inspection, right? We're going to look for tracheal positioning. JVD, we shouldn't see any JVD in a normally hydrated patient as they're sitting up, and we may see slight JVD when they're in a supine position, but it should be slight. So if you're noticing very pronounced jugular vein distension, there may be more than there may be something going on there, right? Either in the ability for venous return, or that the heart isn't pumping sufficiently or with enough contractile force to actually, get rid of the entire volume, right? That 70 milliliters, that stroke volume, or that ejection fraction, right? That 70% of what's in there. In the thorax, right? Look at those chest muscles. Look at that. See if they have any accessory muscle use. Are they barrel chested? Now, if they're barrel chested, okay, maybe they have COPD, right? But that's important to take note, because the risk factors greatly increase. Scar from open heart surgery, right? How are you going to know that? You got to expose the patient. You actually have to put your hands on the patient, kind of feel around that chest wall, make sure it's intact. Feel around for a pacemaker or an internal defibrillator, right? Nitro patches, right? Those can be maybe some not so easily seen, so you have to try to catch that somewhere in your history taking. I check that abdomen. If they have distension, ask if it's normal. Have they had an acute amount of weight gain, visible pulsations? If you see it, right, that AAA, don't touch. You may want to poke it with a stick. Don't poke it with a stick. Also ask about gallbladder, right? Have they had? They still have their gallbladder? Have they been diagnosed with having gallbladder problems? You can even do do a Murphy's test or a Murphy's sign, where you're kind of pushing in and up just above at that rib margin, or that costal margin, just at the under, just above the liver, and seeing if you elicit a response. Extremely, it's uncomfortable, but the difference between discomfort and extreme pain is significant. And if it's significant pain, well, maybe they're having some cholecystitis. But again, if it walks like a duck and it talks like a duck, and we're not a hospital, then we got to treat it like a heart attack. But it kind of leads us into some other, some differential diagnosis kind of stuff. Look at their skin, color, condition, and temperature, right? Like this is even more important than that all so valuable pulse oximetry. Pulse oximetry is great, but skin, color, condition, and temperature pretty much tells you a lot in these situations, almost everything. Auscultate breath sounds, anterior and posterior if you can. If you're really good and proficient and get a chance to practice a lot, you can try heart sounds. It's not very practical in the emergent setting, and neither is messing around with that brewy. Like, don't mess with that kind of stuff unless it's specifically addressed in your protocols. And then you want to palpate. I mean, if you haven't palpated before in that initial or that primary survey, right, you want to palpate that pulse. Radial, if it's not present, you want to check that carotid, right? Because what we're really looking for
is just that indication that we've got about at least a systolic of about 90, which leads us to think that the brain is actually perfusing efficiently, right? That's kind of a good indicator. 90 is a good baseline for that, 90 to 100. And that thorax, again, palpate and expose, feel for sub-Q air and crepitus. Does palpation make things worse? They have symmetrical rise and fall, or are they asymmetrical? Do they have a flail chest? And then again, if pain is present in the abdomen, palpate that quadrant last. So vital signs, right? Heart and respiratory rates, blood pressure. Obtain a baseline set of vital signs and EKG. However, based on your protocol, you may or may not administer any sort of nitroglycerin or any sort of management for an acute MI. Prior to the administration of like a 12-lead EKG, some places really push 12-lead EKG then treatment. Others choose to go, look, if they say they're having a heart attack, we're going to make sure we have a line and we'll start treating, and then we'll get a 12-lead, but we're going to treat the patient first, their signs and symptoms, versus relying on the diagnostic, right, on that EKG. Pulse oximetry is great, but it doesn't take the place of really like touchy-feely. And then get a good blood glucose, right? And that's a blood glucose from your from a good capillary stick, right, versus starting your IV and using the blood, that venous return from the flash chamber. Studies have shown that can show between a 60 and 90, a 40 to 60 milligram per deciliter difference one way or the other in your blood glucometer reading or in your glucometer reading. So you're really taking a chance by not toeing the line on that sort of deal, unless you've been specifically given permission per the manufacturer, in the literature that comes with that device, or by your medical direction that's okay. You're really taking a chance. Okay, so that concludes kind of the review of some physiology, some of the electrophys, and the assessment of the cardiovascular patient, right? It's pretty basic. In the part 2 of this, we're going to talk about the management of cardiovascular emergencies. So take a break, come back, and we will hit that second piece. And it'll be a part 2 on inside the course site. All right, stay tuned.